We're good to go, sir.
Okay. Yeah, good evening, everyone. This is Dr. Kaladhar, head of the Department Critical Care Medicine from Yashoda Hospitals, Malakpet. Welcome to Tuesday's Masterclass in Critical Care Medicine webinars that we conduct very regularly from Yashoda Hospitals in association with Hyderabad IDCCM chapter. So these sessions feature senior examiners and bring forth the sessions from the presentations of students, which help across and cause a lot of knowledge dissemination. And most of the students, they had given feedback that it's very helpful, especially during their exams and all. The other doctors, even in the periphery, they call up and tell that these are very helpful in their regular practice to implement these things. So because it's disseminates the practical knowledge. So today's topic of discussion is burns. For this, we have senior seasoned examiners, Dr. Saroj Prusti, sir, head of the Department of Critical Care Medicine from Virinchi Hospitals, Hyderabad. Welcome you on board, sir.
Thank you. Thank you, Dr. Kaladhar. Yeah, thank you.
And, Dr. Anand V Joshi. So he is the senior consultant from Intensivist in Sydney Hospital from Australia. So he will be joining in a bit. Then we'll welcome him. So the topic of discussion for that, the burns, I welcome Dr. Sindhuja and Dr. Ravi. Both are critical care medicine students from Yashoda Hospital, Secunderabad. I think Dr. Sindhuja, you are good to start.
Good evening, sir. Good evening, sir.
Good evening.
Yeah, good evening. Good evening, sir.
Good evening, sir.
Yeah. So you want to, you are going to present a case.
Yes,
Good evening, sir. Today the topic is burns, sir.
Okay.
Anand sir, good evening.
Yeah. Good evening, Dr. Anand.
Chief complaint is 41-year-old male patient was brought with a alleged history of electrical burns while working on an electric pole, followed by fall from pole on 9th November 2023 at around 12 p.m. at Molladi, brought to ER after 1 hour of the incident. The patient had sustained injuries, burns to the right side of the face, neck, right hand, chest, abdomen, and bilateral lower limbs. He had patient is complaining of pain over the face, chest.
Dr. Ravi,
So,
your voice is a bit low. Can you come close to your mic and talk?
okay, sir. Patient is complaining of pain over the face, chest, right hand, and which was burning in nature. The patient no history of LOC, ENT bleed, vomitings, seizures, and difficulty in breathing. And he had no past medical history. And after arrival to the ER, the vitals are pulse rate 124 beats per minute, which was sinus tachycardia. BP was 90/60 mm of Hg. Respiratory rate was 22 beats per cycles per minute. Saturation was 99% on room air, and sugars was 147 mg per deciliter, and he had pain of VAS score 5 out of 10. On primary survey, the airway is maintaining, and suspecting he had C-spine injury. We have secured with Philadelphia collar, and his breathing was effective, and circulation. We have given IV fluids 1 liter of RL bolus because the patient is having 90/60 of BP, and after that his BP was 110/70 mm of Hg, and disability GCS was 15 out of 15. Exposure temperature was normal. And then secondary survey, the patient is having mixed second and third degree burns over the right side of the face, right side of the chest, anterior abdomen, and over the back and the right upper limb, lower limb, and also left upper limb and lower limb. and the calculated surface of the burns is according to Wallace rule of 9, it is 67%, sir. And no other injuries was noted other than burns. Initially, the treatment started on injection pantoprazole 40 mg IV stat to prevent stress ulcer prophylaxis, and injection fentanyl 50 micrograms IV stat was given, and injection paracetamol 1 gram IV stat was given. IV fluids RL was started 1 liter per hour by calculating the Parkland formula. The injection ceftriaxone 1 gram IV stat was given, Foley's catheterization and done, and Riles tube was placed.
Okay, coming to the Dr. Ravi, yeah, please tell. So, what is your assessment of severity? Here you told that you are, as per the, it is around 67%, the rule of 9. You told that what is your severity here?
These major burns, severe burns.
So more than what is the cutoff, means more than what that you can say that it is a severe burn?
More than 40% of the burns can be classified as severe burns.
What I remember, it's more than 20% if it is a total body surface area. It is. So all us means what degree of burn? Did you assess the degree of burn?
It was 2nd and 3rd degree burns.
How do you assess that?
Based on
How do you assess?
physical examination and based on the physical examination, 2nd degree burns appears red, appearance of blisters will be there, blanch on the pressure, and 3rd degree burns will be leathery, waxy. There will be no blisters. They will not blanch on the pressure. Pain will be mild.
And also involvement of the skin tissues, and epidermis or dermis, and below the dermis, involvement of the subcutaneous tissue and below it. So in
Yeah, but you won't be able to know that clinically, right? Can you say that clinically?
Is that?
So based on the pain and the physical examination, we will divide it into 2nd degree and 3rd degree burns.
Okay. Can you go back to the primary survey?
Sir?
Can you go back to the primary survey?
Primary. Sir.
Yeah. So, what's so specific about this burns for in your case? Are you treating it as a simple, straightforward burns, or what?
This is electrical burns followed by fall from heights. So this is both burns along with traumas.
Correct. Perfect. So your primary survey should include the trauma.
Yes, sir.
Thing, right? So when you have say that airway breathing, airway C-spine stabilization. So what do you mean? What are the particular things you will be concerned in airway in this particular case? Plus other burns, because this is a burns, I will broaden it a bit more. In other burns scenario where the patient is coming out of a fire. So what are the things you will be looking in airway, in the breathing, and in circulation?
In the airway pertaining to the burns, if it is burns of flame burns in a closed space, we have to suspect inhalational injury also, sir. Presence of clinical symptoms and signs related to inhalational injury, and this.
Please name them.
So,
please name them.
Carbon monoxide poisoning, carbon monoxide inhalational injury, and
No, that's what. But how? I see. Yeah. This is a theory you are talking.
So,
you are doing a primary survey. The patient is in front of you.
So,
how will you know what are the suspicion in the examination? Okay, more than examination, you already told me about that. If the patient is got inflammation, it was in a closed wound. So this should go back to your history, because your history though in this case is very clear, but sometimes you have to elicit the history, especially when they are getting transferred out. So if it's a burns, then you will have to elicit out whether it's closed or open, right?
Okay.
Coming to the primary survey, you told correctly. But what actually you are looking?
In case of airway and breathing, we need to look for the presence of edema of the airway, presence of soot in the pharynx, or the presence of any hoarseness of voice or difficulty in the breathing. In this case, especially there are neck and face burns. There will be there may be involvement of the airway causing edema, causing difficulty in the breathing, sir. Also, in the
Can you go it in a bit more systematic way how we will see it? So I think the way you will be looking at it will be you look at the patient, look at the facial involvement, look at more closely, look at the shoot at the nostrils, look at the lip edema, then you ask the patient to open the mouth, then you look at the internal erythema, and then you look, then you go for the, if you are doing a laryngoscopy, then you look for the larynx pharynx. Before that, you will be looking for any airway change. So when you remember these things, you will automatically, when you go in front of the patient, you will start suspecting. So the moment you see something on bad on the face, you will immediately go and look into his nostril. The moment you lick, lips are a bit swollen, you will immediately ask him to open the mouth, and then you go and go for. So that systematic way is also very important because this is a very high, chaotic, and stressed situation. 100 people will be running around and 100 people will be, so these things will get easily missed on this aspect of it. And then cervical spine stabilization, that is true, that will done. Why do you think you have to, suppose the patient has got a lip edema, he's got severe burns, there is a bit of a shoot in that, but he's talking normally. Okay. So what are your anticipation and what are your plan to manage that anticipation?
One is there may be increase in the airway edema, which can cause respiratory failure further, sir.
Correct. So how it is
what if
I
they
have to
first-
selectively intubate the patient with the large size tube to look for the inner edema, airway injuries.
Just for looking for the airway injuries?
And to prevent the collapse of the airway due to edema.
Correct. So you are preventing here essentially from a normal airway becoming a difficult airway. Correct.
Yes.
So that would be because there will be provided you are trying to do that and some surgeon will come, oh, everything anni baane undi kada maatladutunnaru kada enduku why you are trying, just you because you ICU people are there you will do like this, but no, you should be able to justify your answer or tube the patient. Okay, it's very, very important, right? And okay, then next in the bit of a breathing thing, what are you looking for the breathing things?
One is respiratory rates, sir. Patient who are in altered sensorium or altered mental status or depressed GCS may have decreased respiratory rate or unable to clear out the secretions and all. And patient who are in electric burns may have sustained respiratory muscle contraction leading to respiratory arrest. So we should see for respiratory rate. And because of the pain, they may not be able to breathe properly. That another reason we should also see for the breathing respiratory rates and medication.
Yeah, just staying here only in airway breathing circulation, you realize that this person requires an intubation, right? How will you go ahead with the intubation in this patient?
This patient does not need intubation.
Assuming he requires an intubation.
Sir, pardon.
Assuming this person requires an intubation. Let's assume that this patient, you saw this patient, airway is maintaining, but you realize that he's got a shoot or he's got a bit of a sore thing and all those things. How will you intubate the patient? You need to know why I'm asking this question.
Rapid sequence induction and intubation, sir. With
Okay, can you elaborate that on, please? How will you induce the patient?
Induction with fentanyl 2 mg per kg IV or in 1 to 2 mg per kg IV, followed by rocuronium 1.2 milligram per kg IV.
Rocuronium is not available. So said I have succinylcholine.
We can give succinylcholine within 24 to 48 hours of burns. But here in this electric burns, there will be risk of rhabdomyolysis and cell lysis causing hyperkalemia. So we should be cautious regarding succinylcholine.
Cautious or contraindicated? And if you're saying cautious, what are the cautions you want to take?
We can see the ABG in the potassium in the ABG.
Yeah, so that cautious is not a correct word. No? Yeah. You said it's unless and unless proved otherwise or contraindicated, you shouldn't be using it. Any of the depolarizing muscle relaxer. Correct?
Yes.
So this is very, very important whenever you are, especially you will be the only person there. And it's not there, succinylcholine given, you tube and the patient arrested. And you're scratching their head, why? I know the recent studies, they are not so much in the favor and they say that it's hyper out of the proportionally this has been kept, but traditional teaching always still remains the truth. So maintaining the airway and intubating the patient is an important aspect in any burns patient. And that has to have an early recognition to prevent it from going into a difficult airway. Right? Coming to your circulation, any specific things you would be concerned or looking in a circulation? You said, how will you look for the circulation in these patients?
Circulation, we'll check for the heart rate and blood pressure, sir, and we'll check
how
for
will you check the heart rate and blood pressure?
And these patients will have tachycardia, sir, and this concern with the electrical injuries, they will have more of arrhythmias, cardiac risk of cardiac arrhythmias, and
correct. So let's go switch back to non-electrical burns, in the inflammable burns. How will you look for the circulation and what in specific you will look for circulation?
Circulation.
Suppose you have this 67% of inflamed burn, which will involve the upper torso, right? He's got a hands, he's got a legs, everything is burnt up, right? So what in particular you will be looking when you're looking at a circulation and how you will be looking at it?
First, this heart rate we'll see, sir. Heart rate, we'll look for the ECG changes, sir, because any patient with the burns will have hyperkalemia and risk of arrhythmias will be there, sir.
Agreed. Agreed. Next.
Next, we'll check for the blood pressure, sir, and look for the tissue perfusion also, sir, because we'll check for capillary refill time. We'll see, so
Basics and the lactates in the ABG may help in.
Okay, so lactate is high, blood pressure is 110/70, heart rate is 120, and you see that capillary and urine output is good. So where you will see the capillary filling?
In these cases, capillary refill is not reliable, and in the burnt area, we cannot see.
Why should not be reliable? Suppose there is a distal, the palm is not involved, and you are seeing the capillary filling in capillary filling is low.
If the we should not check for the capillary refilling time where the injured burns area is there, sir.
No. Why is that so? Why is that so?
rhythm.
Because any compromise in the vasculature, we cannot be accurate in capillary refilling time.
Correct. So that is that a concern, or you should be ignoring that point?
It is a concern,
Concern,
sir.
sir.
In first and second degree, there may be arrhythmia. In third degree, the vascularity may not be seen, like they will be pale and waxy tissues.
Yeah, but if the distal, suppose the palm is not involved and your capillary filling is bad, what are your concern there?
That the patient is in hypovolemia.
No, but heart rate is 120, blood pressure is 110/70. Where is patient is hypovolemia? So what I'm trying to draw your attention is we tend to forget the regional compartment syndrome that may ensue because of the circumferential burn. The patient is wearing the clothes, you have not removed the clothes. The patient is a female, and you have just kept that all the clothes and things, and there is a big tightening circumferential burns which has gone into an eschar, and that is compromising a limb. And you are sitting in your room, you have not seen the patient, and you have only trying to treat the lactate and the heart rate and the blood pressure, but forget to see that this limb has completely been compromised, and that is one of the emergency indication to call the surgeon and do escharotomy.
Yes.
So that thing, because all these things are time bound, if you lose the time, hand is gone completely, right?
Yes, sir.
We have still not gone ahead. We are still at the basics. So airway, what you want to see, breathing, what you want to see, circulation, what and where you want to see. Okay.
Yes,
In the
sir.
same way, for the circulation, when you're doing the thing, always remember to do after ABC, you're done an exposure.
Yes.
Okay, let's come back to that. We'll come back to that. So this is what I wanted to you guys to know, that in circulation, do not forget the regional involvement. Just having a high lactate, targeting lactate, having a good urine output is not enough. Okay.
Yes.
Emergency escharotomy is an important component. You will have to sit on the head of the surgeon to do that.
Yes.
Okay. And disability wise, GCS and exposure. After that, what? So you have done the primary survey.
Yes, sir.
Right? What is between you are going to do, and after that you have done go to the next slide, secondary survey.
Secondary service.
Okay. So what you do in between primary and secondary survey? Why they say it as a primary survey and secondary survey as a different one?
This primary survey plays a vital role, sir. If any abnormalities in the primary survey in the airway, breathing, and circulation, will resuscitate, sir. Will resuscitate and and stabilization of the patient. Followed by, we'll check for the secondary survey for any other injuries, sir.
Correct. So anything in between you want to do between the primary survey and secondary survey? Okay, anyway, to cut short the thing, usually you, after the primary survey and after you have seen that everything seems to be okay, under control, bloods, tubes and lines. These are the 2-3 things you have to immediately do it. Okay, so take the blood, take a wide bore cannulas, secure the line, get the lifeline in that, and address to the pain, and then you can go. Otherwise, that person is moaning, groaning, and shouting and howling, and then you will be sitting and calculating the percentage of the pulse. Right?
Yes.
So after primary survey, lines, tubes, and bloods. Okay. The same reason why you want to secure the airway, you should also put in a NG tube and the urinary catheter.
Yes.
Right? Especially when there is a burns area, because once that thing, it is extremely painful to put that. And once you have put it in, earlier you put it in, the better it is.
Yes, sir.
Okay. So primary survey, lines, tubes, and analgesia, and then come to the secondary survey.
The purpose of emphasizing here is basically at the time when you inspect and you are doing primary survey, there may not be an indication for intubation, putting a tube,
Yes.
but prediction of complications at primary survey is more important than what you are doing at that moment. So
Correct.
you may feel at time there is no indication for intubation, but what you are predicting the complication, accordingly you have to take a step.
Yes, sir.
So regarding same, when coming to circulation also, you feel that patient is hemodynamically stable, lactates are normal, your capillary refill time also normal. So do you want to resuscitate the patient with fluids?
Yes.
Yes, sir.
Why is that?
Whether it is a hyperbone.
Why is that?
That is one. Yes. Another scenario. A patient you have evaluated, you have done the echo, means screening echo, and you have done the E-fast, you have looked at IVC, you look at cardiac function, you have looked at all these things, and there is a severe cardiac dysfunction is also there. How to give fluids? So first question is, everything is normal. Do you want to resuscitate with fluid or not? Lactate is normal, capillary refill time is normal, everything is normal.
Yes, sir. In case of burns, yes, sir, there will be ongoing third space fluid loss because of the capillary leak and systemic inflammatory response syndrome. So we need to give fluids irrespective of the lactates and the normal BP in the starting.
So what is
What would be your target?
Yes.
Urine output of 0.5 to 1 ml per kg per hour in case of flame burns, and in electrical burns 1.5 to 2 ml per kg per hour is targeted.
Why is that difference?
In case of electrical burns, risk of rhabdomyolysis and risk of AKI will be there. So high urine output is targeted in electrical burns.
Is it recommended to give fluids as per the urine output? You are working in a best of best centers. You have all facilities available, everything with you. So is it recommended to go for a fluid resuscitation in a patient of severe burn? You are saying it is more than 67%. So whether it is a flame burn or electric burn, but this point of time, do monitor the urine output and give the fluids? Is it recommended?
Or to put the same question in a different way, you got everything. You got PICO, you got pulmonary artery catheter, you got LIDCO, everything, advanced cardiac output monitoring is there. Will you still give as per the
Previously, where the facilities are not there, these formulas are used, but based on the urine output and based on the lactates urine output, we can assess and we can resuscitate the patients.
No,
the Parkland
thing
formula
is,
or
so what will be like, say, fluid resuscitation, that is a concept, that is most important concept is burn suck. You know what is burn suck?
Burn shock, it is a distributive shock because of the vasodilatation due to capillary leak syndrome and inflammatory response. So initially patient may have normal BP, but they may go into hypovolemia and hypoperfusion of the tissues because of the loss from the intravascular compartment into the third spaces. So we need to give the fluids ongoing in the first 24 hours according to the formula.
Yeah. So irrespective of the condition of the patient, so even though patient is hemodynamically stable, you are predicting that in the few hours patient is going to lose a lot of, because it is a combination of all type of shock, distributive shock and volume loss, hypovolemic shock and cardiogenic shock. Because a lot of inflammatory cytokines, even they depress the cardiac function too. So for that reason, you need to reassess and give the fluids. So if a patient having other dysfunction, if a cardiac dysfunction or a CKD patient already on dialysis, where you cannot give a volume to a patient, is it the same rule applicable that you resuscitated with the IV fluids? And if you want to resuscitate, how you want to resuscitate? How you want to resuscitate?
With the close watch on the saturation and
Are you getting my point? Are you getting?
Yes, sir.
Are you getting my point?
yes, sir.
Yes, sir.
Yeah. So how will you resuscitate? You told for a normal patient, because patient is going to burn suck within few hours, you want to resuscitate with fluids. In a scenario where there is a situations where contraindication to fluids, you cannot load with the fluids because of underlying condition. In that situation, how you are going to give the fluids? In the same way you want to give, or any other thing you want to do, anything extra you want to do?
He'll start resuscitating the patient, sir, and during resuscitation, we'll check for the saturation and presence of B lines and lung ultrasound, sir, because the patient is having cardiac dysfunction. And
Okay.
uh,
With that, you need a continuous hemodynamic, advanced hemodynamic monitoring is important in this situation.
yes, sir.
So pulse pressure variation, global end diastolic volume index, these things, extravascular lung water index. So all these things, parameters, if you monitor them, and there is a, even because stepwise approach will be there. How to give the fluid, how you want to resuscitate the fluid when you have all the facilities. You have with hemodynamic monitoring with you. So you have placed everything, you have a PICO or you have a EV1000, everything with you. So how you want to resuscitate by monitoring this advanced hemodynamic monitoring? How you want to give the fluids? Because you need to check the fluid responsiveness. You want to give the fluids and you have to, at the same time, you want to resuscitate also. Do you know? Because tell me.
We'll see for stroke volume variation and pulse pressure variation. So if it is more than 30%, we'll consider it as fluid responsive.
13 or 30, 30?
13, sir, 13.
13, okay. Okay. So so there is a, like, if suppose you are for pulse pressure variation, patient needs a mechanical ventilator. There are some few steps which are mandatory for to measure the pulse pressure variation. Patient should be on ventilator, low tidal volume ventilation, patient should be sedated, RAS score should be less than, so many parameters are there. Suppose it is patient is not fitting into the monitoring for a pulse pressure variation. Any other parameter you can monitor which will be helpful to you for guidance of the fluids?
IVC distensibility index.
Okay. How the right heart function, how it will help right heart function? Can you look at in the echocardiography also, you can see the right heart, the filling pressure, right heart function. And if you have this an hemodynamic monitoring, then global end diastolic volume also you can see. Even you can see the extravascular lung water. So one is for resuscitation. Then what fluid you want to give and how much fluid you want to give. This, because this is a burn topic, it is very, very important that resuscitation is for as a critical care. It is bread and butter, I think. So we need to know regarding details about the how you want to give.
In case of burns, oral is preferred, sir. Oral is the preferred one because with NS risk of a hyperchloremic acidosis will be there. And
any other fluids you can give? Can you give starches?
No, usually not in the first 24 hours, but if the crystalloid is going up to more than 1.5 times the estimated Parkland formula, we can start colloids as early as 8 hours following burn injuries. Hydroxyethyl starch and all, there will be risk of coagulopathy and renal failure with the hydroxyethyl starch. So crystalloids are preferred over colloids initially.
Is anybody using hydroxyethyl starch?
No.
No.
Is it still marketed? It should be out of the market technically. It shouldn't be there. Even if some old stock is there, throw it away.
Yes.
No, it will be criminal. It's not. It's an established thing. It's been established in a histopathology that it screws up the kidney. Anyway, let's move forward. Otherwise,
Yeah.
we'll
Yeah.
talk.
Yeah, no.
So you guys
no.
got the thing, no? Primary survey, secondary survey, and getting lines and tubes, early recognition. Okay.
Yes.
So that's very important, and it is not only from the exam point of view, it is also from the practical point of view. Because burns is something which what you see may not be true after half an hour or 45 minutes. This is one place where you have to be really careful. And one of the questions to ask in electric burns is to rule out any fractures. Yes, that does come under the secondary survey to rule out any fractures and all those things. But we are focusing here only on the burns. That's why we are talking only of the burns. Okay. So the reason the burns is very tricky and typical thing is everything is wrong about burns. First of all, it is extremely deceptive. What you are going to see after 2 hours will be completely different picture than what you are seeing now.
Yes.
What you are going to see after 24 hours will be completely different picture than what you have seen now. So it's a very tricky, and the treatment goes in hours rather than days. Okay,
Yes, sir.
let's move forward. What are the other ways you can? I mean, this is a theoretical question. Other ways of calculating burns, percentage of burns.
The contiguous burns in adults, rule of 9 is followed, Sir Wallace rule of 9. In pediatric patients, London Browder chart is preferred. And in
London Browder chart is also for adult.
both adult and adult. And in non-contiguous area, Palmar surface, based on the Palmar surface, 1% for each Palmar surface.
Correct. There are 3 ways to do that. So your initial treatment.
Yes, sir. Initial treatment, injection pantoprazole IV stat was given. Injection fentanyl 50 micrograms IV stat was given, and injection paracetamol 1 gram IV stat. And IV fluids was started, sir, according to Parkland formula. And injection ceftriaxone 1 gram IV stat was given, and Foley's catheterization and Ray's tube was placed.
So pantoprazole, why did you give?
Sir, this burns patient, there is high risk of.
How did you give, by the way?
Sir?
How did you give? We are starting with the initial management of the patient, right? You give intravenous. Did you secure IV cannula?
Yes.
Sir.
Large bore IV cannulas were secured.
Were secured? Okay. No, you didn't tell me that. I didn't know that. And suppose IV cannula are not securable. What are the other things?
Can go for the central venous
preferably
catheterization.
in the non-burn.
Patient is hypotensive. Central venous catheter is difficult. Yes, eventually you will end up putting it, but anything before that?
In child, intraosseous route is
Why only child?
in adult.
Adult also you can put it, na? You should be having the guns, no? Now.
Intraosseous,
Have you gone to a ER? Have you looked into it? I'm sure there is a gun intraosseous? Kaladhar?
Sir,
You're having that intraosseous gun, na?
no, sir, not many of the hospitals have intraosseous gun.
Otherwise, you have those hand things. And
Yes,
what
sir.
are the sites where you put it in?
Lower 1/3 and medial surface of the tibia, sir.
Lower or upper? I think it's upper. Yeah. Keep this thing in mind because it will become once in a lifetime thing.
Yes, sir.
So certain things you have to keep in practice and keep on repeating in the mind. Because suddenly out of the blue, you will be in a situation where you don't have IV cannula. The only thing remains is the introduction. Somebody will hand you the gun, and when if you have, it will be always the first time in your life. But then you need to know where it is you have to go. Okay.
Yes, sir.
Right. So you got an IV thing, and then you give IV Pantop. Why? And that was your first treatment. The first thing you did was get an IV cannula and give pantoprazole. That's what it gives me an impression.
No, sir. Actually, after placing an IV cannula, we initiate resuscitation with the fluid, sir, followed by pain management, and then we'll
Other things.
give the
Okay.
other things, sir.
But your initial treatment, what you have written doesn't reflect that, no? Okay. So
Yes.
let's go with what you are saying. You started with the initial fluid resuscitation. Now, can you elaborate that, please?
We start with after calculating Parkland formula, we start giving IV fluids with
Calculate.
so
Calculate, please, for this patient.
we 4 ml per kg per percentage of body surface area will give, sir. This patient has 67% of burns and
Assuming 70% for the easy calculation.
so 70% into 40, 70 into 70 and 4, sir. It comes around 18 liters, sir. And this 18 liters, first half will be given in the 8 hours, and next 16 hours, next half will be given, sir.
Who is going to give instruction to your nursing staff that you want to do this?
Yes, sir. This first half comes on around 9 hours, sir. It comes around 1.2
I
liters.
agree. I'm agreeing with what theoretically thing you have said. The
Yes, sir.
patient is in front of you. You have secured the cannula. Now you tell the nurse what you want to do. This is what is going to happen. You can't just fly your hands in the ICU or in the ER and then walk away and go away and start and come back and abuse nurses. You have to document what you want.
Will say to the nursing staff that this much fluid should be given per hour, sir.
A fluid, sir.
RL, sir. RL ringer lactate fluid should be given in per hour.
So, ringer lactate. Start a ringer lactate solution.
Ringer lactate 1.2 liters per hour should be given, sir.
1.2 liters per hour.
Yes, sir.
Okay. So she will come, she will put in a pediatric drip set and she will now start counting the drops.
Infusion pumps are there. Those infusion monitor pumps are there with this, so we can.
This is practically is what going to happen, and the patient will be dead by the time you go to coffee and come back. And this happens. Believe me, this happens, and it happens everywhere across the world. Don't think that it doesn't happen here. It happens there also. Here also. Okay. So give clear instructions. You can't tell to the nurse, sister, please give this patient, resuscitate this patient as per the Parkland formula. I will be coming back. No, you tell there, stand there, put a IV cannula. You don't ask a sister for putting an IV cannula. You put a IV cannula. So it's going to be a difficult one. And she's going to spend next half an hour in putting an IV cannula. So tell me, you have written at IV fluids RL at 1 liter per hour. RL is not there, out of stock. Ledu. I got NS. Any crystallite or NS or RL, take it, hang it 1 liter back. Let this 1 liter black flow over next 1 hour for next 4 hours, something like that. You have to tell, which has to be perfect, crystal clear. Okay.
Yes.
So fluids you have started. Next. So you got IV cannula, you got a fluids. Now, the next one will be pain.
Pain management.
Pain management. And then this one is what? Ceftriaxone.
Ceftriaxone, 1 gram IV stat was given, sir. Initially.
Why?
Why you
Ritual.
have started antibiotics?
Now forget about antibiotics. Ceftriaxone. What is the treatment of fever in India?
We give
Ceftriaxone.
paracetamol there.
No. You give Ceftriaxone. Treatment of headache. Ceftriaxone. Any temperature above 37.5 in India, first thing we give is IV Ceftriaxone. Correct? But that's not the way it is. Why was Ceftriaxone given to this patient? And that also electric burn. If at all any bacteria were there on his body, would be electrocuted. I know you are not the one who had given, but just keep this thing in mind.
Sir.
Everything is not Ceftriaxone. Unless you got a shares and you got a factory in that. That's a different issue. Okay?
Yes, sir.
Police
Do you
catheter
want
and
to give
RT.
prophylactic antibiotics?
There is no role of
No?
prophylactic antibiotics in the burns.
You're contradicting your slide, madam.
Practically, how do you think, sir? Is it feasible? Like practically, whatever you said is correct. But practically, many it's being open ICUs.
Oh wait, there is
yeah.
no question of practicality. There is no question of practicality. I am 100% not sure that with so much amount. In fact, just now your high tech had this antibiotic thing big conference.
No, as critical care physician, we agree, sir. But how to
Yeah.
practically? Yeah.
I think this person has
other
still not
clinicians are
getting
involved and
admitted anywhere. This patient has still not got admitted anywhere. They are still in the resuscitation phase. They are still in the ER and the critical care. The admission is still not done. You don't need to give that. And the reason I'm saying is in the first slide of the management, before the IV cannula, before the fluids and before the pain has reached, there is a ceftriaxone sitting there. Correct? So this is what the psyche we have to change for the next generation.
What are the situations where you consider the prophylactic antibiotic? If you want to give, you told that there is no recommendation. There is no recommendation for a prophylactic antibiotic because to avoid resistance and all these things, resistance pattern is very high. So you don't want to give prophylactic. But any situation where prophylactic antibiotic has a role in burns patient, severe burns.
Contaminated, if any burns contamination is there, then we can give prophylacticals.
Yeah. Or patient is
Anything else you are missing here?
immunocompromised.
Anything else you are missing here, which is very important? This person had an electric shock, fell down on the ground, and had bruises and injuries. Okay, I will give you a hint. I will add something in this so that you can immediately know. He was hit on an iron rod.
Any vaccine you want to give?
Tetanus toxoid, if not a booster dose, if not given in the last 5 years, we should give tetanus toxoid.
That fellow is unconscious. He is not able to tell you.
Then we should give TT.
Yeah, that should come on the first page, na?
Mm.
I'm sure this patient was not given TT. No, no.
Yes.
Remember, tetanus is still incurable disease. You will bump once in a while, and you will repent why I didn't give it. Comes once in a while, but it's a disaster, absolute disaster. Okay, let's next. Let's go next.
Initial investigations which have done our complete bed picture, renal function test, serum electrolytes, serum creatinine, phosphokinase, and electrocardiogram, and arterial blood gas analysis, liver function test was done. So, in that we have along with this we have gone for CT polytrauma, sir, because the patient has fall from height, so we have gone for CT polytrauma.
ABG, BBG, both different were done, or it was just a routine thing? Any specific reason you did BBG, or it was BBG was done in the initial before ABG was done?
BBG was done initially, sir.
Always try to, this is just a comment, always try to be specific when you're ordering the bloods. Make a habit of it, because every hospital will have a different kind of thing. Okay, so some people will write SP1 and SP2. Did you do SP1? Literally, it will be written like that, SP1. What is SP1? It is the same understanding as RFT. SP1 is surgical profile 1. CP1, cardiac profile 1. CP2, cardiac profile 2. This is a bad culture which has really gone into our brain. So when you say renal function test, you better say serum creatinine, serum urea, serum electrolyte, sodium, potassium, magnesium, calcium. Please say that.
Yes.
Otherwise, you will end up somebody more intelligent than you. Oh, you don't know SP1. Send SP1. If that hospital is having a lot of urology, then you are one. Urology profile 1. And then you will be scratching your head. Okay?
Yes.
CT polytrauma. You should always say what CT polytrauma you did. Be
CT
specific.
Suspecting head injury and spine injury and chest, abdomen, and long bone injuries. We have done CT brain, CT spine, CT chest, and abdomen and long bones, where we could not.
May open up another whole gamut of following a trauma, but let's not go there. But then ruling out C-spine injury is another complete different topic. Probably that should for that Kaladhar will have to organize another thing. But let's go ahead with the burns thing.
What is tertiary survey? What is a tertiary survey? You have done the secondary survey. What is tertiary survey?
We reassess the secondary survey, sir, after the investigation.
Anything else? What is the concept of doing a tertiary survey? Means you are looking at for complications, which the primary condition patient presented with severe burns, and you are managing with during the simultaneously managing you are doing with primary and secondary survey, and during follow-up when patient is developing complications secondary to your primary condition and ongoing treatment, that monitoring part, assess and prediction is called tertiary survey. So what are the complications you are predicting in this case? You have given a lot of fluids because as a fluid resuscitation, you have given a lot of fluids. And you all started antibiotic, you started fentanyl for painkiller, you have started pantoprazole, all this treatment as an initial resuscitation, you have started all these things. By 48 hours, by 72 hours, what complications you are expecting in this case, so that you need to monitor in the tertiary survey. And which is the most important complication you are predicting in this case? You have done some of the related investigation also.
With the fluids, there will
Patient
be
is bloated.
yes, a risk of
Please go ahead.
fluid entering into the third space, causing the edema in the both burn and non-burn tissues. Risk of compartment syndrome will be there, sir. Risk of compartment syndrome will be there, and pulmonary risk of pulmonary edema, and with opioids, a risk of respiratory depression and secondary respiratory acidosis or desaturation can happen.
Yes.
And
yes. Yeah. Go ahead.
No.
Okay. So how will you manage that condition? Suppose you found that patient is having edematous, anasarca is there, third space loss, and you have given a lot of fluid, abdomen is distended, urine output has decreased, CPK level is high, creatinine level is also high, potassium is high, patient is having acidosis, breathless. So how will you manage this condition? And when you are looking for a fluid responsiveness, patient is still, it is showing that patient is fluid responsive. How will you manage that case?
In such cases, we can give colloid survey. They'll have high oncotic pressure and
you have to name the colloid. Don't answer colloid. Don't answer colloid. You have to name the colloid.
5% albumin. 5% albumin is preferred ones.
Small volume resuscitation, 20%. Even you can consider for a 20% albumin too, because it's a small volume resuscitation. So
do you get 5% albumin?
Yes, 5% and 20% are available. So
okay. If you don't have 5% albumin, will you go for it? How will you make 5% albumin? Can you put 20% in a liter of saline or 500 ml of saline? Will it make 5%? It's the same thing, na? Just a diluted one. You can do that. Anyway, let's go to the next one.
Yeah, next, what to do? How to, at the same time, how you will monitor the patient? You told that patient is having intra-abdominal hypertension, abdomen is bloated. You need to monitor the intra-abdominal. Is it recommended?
Pressure we need to, in case of chemical if you are paralyzed only, we can monitor the urinary bladder pressure. So otherwise, we can see for in case of intra-abdominal hypertension to look for any end organ damage, urinary output monitoring should be done.
But what I'm asking is it recommended to monitor intra-abdominal pressure routinely in all cases of burns? Yes or no?
No.
So you want to monitor only when patient is having signs of intra-abdominal pressure, hypertension.
In the awake, spontaneously breathing patient, we may not have accurate intra-abdominal pressure measured with the urinary bladders.
I agree.
Okay. If a patient is on ventilator,
Yes, sir, who are paralyzed and we can
so you
measure
can
with
tell
police.
the intra-abdominal.
Yes.
Yeah, with police. But because of large volume resuscitation because of in severe burns and the risk of complications are high. So as per your fluid resuscitation, you are giving a lot of fluid. So for that reason, you need to monitor the intra-abdominal pressure. So that your de-resuscitation, you can do at proper time, you can go for a de-resuscitation. Okay. So next, you told that this patient you have started fentanyl, but you told that your degree of burn is grade 3, no?
Mixed burns, sir. Superficial partial thickness, deep partial thickness, and third degree ones. Mixed burns were there.
Mixed burns were there. So for that reason, patient was having pain. At the same time, patient had a skeletal injury also, no?
No
Because
skeletal injuries were there.
skeletal injury. Okay. But patient had a pain in the burnt area.
Yes.
Okay. Okay. Besides fentanyl, any other drug you can prefer, or as a pain relieving agent?
Ketamine can be given.
How will ketamine help in this?
It maintains it is analgesic, sir, first of all, and maintains preserves the. Sir,
How ketamine is analgesic?
NMDA receptor antagonist.
Was it dissociative anesthesia? No? It dissociates between your perception and this thing.
Yes.
That way it's analgesic. Anyway, next slide.
What you have done, carboxyhemoglobin 2.8%. Was it normal or abnormal? You have done the carboxyhemoglobin, it was 2.8%.
It is normal. Less than 3%
Normal.
is considered.
So means below how much it is normal?
Less than 3%, sir.
1 to 3% in non-smokers. In heavy smokers, it can be up to 10%.
How to suspect that somebody is having a carboxyhemoglobin? Means carbon monoxide poisoning.
One is presence of any altered mental status, symptoms like giddiness, nausea, vomiting, seizures without brain injury, and persistent high lactates, acidosis without a
High lactate in the carbon monoxide poisoning?
No, sir,
I
it's
don't
seen
think.
in the cyanide poisoning.
Yes.
In carbon monoxide poisoning, only symptomatic, like if it is 20 to 30% headache, nausea, vomiting will be there, more than 30 to 40% seizures followed by comas.
Okay. So how will you manage if you have a suspicion, high suspicion for that? How will you manage carbon monoxide poisoning?
100% oxygen will reduce the carboxyhemoglobin T half from 4 to 6 hours to 40 minutes. 15 liters oxygen with non-rebreathing mask for 40 to 60 minutes we should give. If it is more than 40%, then we will give hyperbaric oxygen therapy. In pregnant patient, more than 15% of carboxyhemoglobin, we will give hyperbaric oxygen therapy.
Just to answer this question, what you answered is correct, but always again go start with the relevant history where you are suspecting it, and then come back to your again airway, shoot, blackish color shoot, edema, and then you go with these symptoms. So it's always good to that because those are also a part of your inhalation injury. It's a part of your inhalation injury, right?
Yes.
So always keep this thing, even though it gets repeated, always keep this thing in mind.
So in this patient had a any entry wound or exit wound
Because you will get once in a while these things.
Sir, we could not find out, sir, actually entry and exit one destination.
But because it was an electric injury, electrical burns.
Electric burns,
Electric
sir.
burn.
It was electric.
So which is more harmful or dangerous, or risk of complications are very high? Entry into it or exit wound? Anyway, you told that cardiac arrhythmias are more common in electrical burn injury. Exit wounds are more dangerous than the even entry wound in electrical burns. The burns will be more severe in the exit wounds. Okay. Next slide.
Complete bed picture, hemoglobin was 16.3 and hematocrit was 46. Total counts was 12,300. So platelets was 2,54,000. In renal function test, blood urea was 36 mg per deciliter and creatinine was 1.5. Serum electrolytes, serum sodium was 138 and potassium was 2.9. Chloride was 106 millimoles per liter. Serum creatine phosphokinase was 18,924 units per liter, and PT-INR was 15 and 1.1 seconds. Blood group was O positive.
So what is your impression from the lab values?
There is a presence of rhabdomyolysis.
Yes.
Yep, you have to keep in mind.
High hemoglobin is very
Yeah.
high.
Hemoglobin is very high.
Also.
So hematocrit is also there, sir. So he's having suspecting third space loss and causing high hematocrit, and serum creatinine was 1.5, sir. So borderline.
These are all day one investigation lab values.
Yes,
Yes.
sir.
Are they all day one lab values?
Yes, sir. Baseline lab values. Day one.
Yeah, baseline at the time of admission.
Yes.
Correct admission, sir.
Okay. So that point of time, you suspected patient already had rhabdomyolysis.
Yes, sir.
But your potassium level was 2.9.
Yes, sir.
So how did you confirm that patient had a rhabdomyolysis?
Here, based on serum creatine phosphokinase was elevated, sir, 18,924.
Okay, that is fine. But how did you confirm that patient had a rhabdomyolysis? How to confirm it?
Is he expected to have a high CPK?
Yes, sir.
In electric burns.
Electrical
even
burns
30.
with 67% of mixed burns can
Expected, no?
expected.
So is it an established rhabdomyolysis or this guy has a risk of rhabdomyolysis?
It is an
This is the another way of what Prusti has asked.
Yeah, I wanted to ask. Yeah.
So Prusti gave the one question. I'm giving the same. The answer to that will be the same as what I have asked. There is a two different thing, right? The person having risk of rhabdomyolysis and one having an established rhabdomyolysis. Okay, if there was no CPK, how would you have suspected?
high presence of high colored urine, hyperkalemia.
Correct. बोल ना हो. Hyperkalemia दिखता थोड़ी है. You have a high colored urine. So why that high colored urine?
Because of the passage of myoglobin in the urine.
What you will check now?
Urine
that means that
myoglobin levels or the total.
Yes. Why you are not
that
answering that?
asking. That is what he's asking.
Urine
Urine
myoglobin,
you said that's an established rhabdomyolysis with renal failure. Correct?
I need to urine myoglobin, then confirm my diagnosis. Okay, next.
The initial treatment.
I have a problem with this statement. IV fluids continued. Please explain. What did you do? No, I'm very particular on this specific burns because, as I said, first hour IV fluid, Next 8 hours IV fluids, 24 hours IV fluids, and after that IV fluids. These are our specific things. You can't generally say
And
that.
yes, and particularly burns case.
And particularly in burns. Other things I agree. IV fluid continue, ceftriaxone given, patient, everything was done. Those things I agree. Patient resuscitated and stabilized, hemodynamics made well. I agree. But in burns, you tell me. IV fluid continue means what did you do?
This is initial 24 hours, sir. So we are, based on Parkland formula, we are continuing giving IV fluid, sir. And based on the lab values, we have started with additional treatment like alkaline diuresis, sir. This initial 24 hours region.
He is not going to like that answer. He has already taken you that you have already filled the patient and you have already gone into pulmonary edema, everything he has asked you. So you continue, you're still saying I have continued fluid. So you, when you say based on, not on based on formula, you have to say the target. So IV fluids were continued as per Parkland formula, however, in a cautious way, maintaining the urine output 0.5 to 1 ml per hour. So you should have explained that his urine output remained or was maintained like this. Right. And when you are suspecting a rhabdomyolysis, what is the target for urine output?
Up to 2 to 3 ml per kg per hour.
2 to 3 ml कुछ ज़्यादा ही हो जाता है, 1 to 2 ml per kilo. Okay. So then why did you start alkaline diuresis? So you should have told that his urine output was 1 to 2 ml per kilo. And you don't need alkaline diuresis. Correct?
Yes.
That's it. And these are all established things. These are not individual opinions. And everything is given in book. And that's how we practice. We should practice that. Okay.
Yes.
70 to 80 mils an hour, maintaining saturation. Good.
Yeah, next.
Are you worried about tachycardia?
Yes, sir.
Okay. It's a search response.
Yes,
Day 2. 10. Oh, you are well resuscitated him. Very nice.
Yeah.
Patient is having sinus tachycardia, sir, and mean arterial pressure of 70 and maintaining urine output around 80 ml per hour, and high colored urine was noted, sir. And lab parameters, hemoglobin was 16.7 and PC was 51, and total counts was 8,980 and platelets 1,80,000. Creatinine was
Nothing
0.6.
specific. Yeah, nothing specific in this, right?
Okay,
You have to convey anything specific on this slide?
No.
No.
Next.
Okay. But at this point of time on day 2, now everything is normal. Look, so you have optimized well with fluids and other things. On day 2, anything specific you need to take care.
Colloids. Presence of
Means
fluid
want to resuscitate.
overload should be seen, and he has still high colored urine, rhabdomyolysis, and is going on. So
Yeah, but your creatinine has come down, no? Normal. Why you want to be worried about it? Anyways, it's secreting everything.
risk of compartment syndromes should be seen
Where?
in the limbs and abdomens.
How will you see?
Like clinical features like pain out of proportion, on pain on passive stretch of the muscles, paresthesias below the level of pressure will be there. And
Decrease circulation below the level of compartment and all those things.
pulses, the peripheral pulses should be seen.
Peripheral means that specific compartment. If he's having compartment syndrome on the left side, and if you'll say that the dorsalis pedis is palpable, yes, palpable. But you don't know that your registrar or the nurse has seen the right side of dorsalis pedis. You have to see the left, the same limb, na?
Yes. In one.
Okay, move on.
So you mean to say that on this slide you wanted to highlight high colored urine and ongoing rhabdomyolysis, is it?
Yes.
Yes, sir.
So does that, will it be affecting based on this data, affecting your current strategy of maintaining the urine output and alkaline diuresis, or you want to leave it as of now?
We should continue the fluid resuscitation and diuresis when there is
With the
ongoing.
targeted, correct. Okay. Next. Shabash.
We have placed central venous catheterization, and we have continuing the fluids at the rate of 250 ml per hour, sir. And alkaline
This is day 2.
Yes, sir.
Yes.
Yes, sir. Day 2. Sir.
Why after 24-48 hours? His blood pressure came down, heart rate was normal, creatinine has come down normal, white cell counts have come down normal. Any other reason? Okay, soda bicarb we are continuing for with 5% D is for the alkalization. And you have added vitamin C and human albumin. Any particular reason?
Vitamin C, it has a role in decreasing the fluid creep, sir, and it promotes epithelialization, the burnt tissue.
It will
Is there
have
any study? Is there any study to say that?
Yes. There is
How
a
will
small randomized control trial where 66 milligrams per kg per hour of vitamin C was given, which reduced initial 24-hour fluid requirement and number of ventilated days. In one
burn
study.
patient?
Yes, in one study. But there is no particular guidelines or proper evidence of vitamin C in burns as of now.
Okay.
Usually it prevents the
What's the problem with the
intrapulmonary.
vitamin C in the current situation? Suppose a nephrology comes and freaks out. Will you still quote this study? Or you will ask why he's freaking out? What's the problem with vitamin C?
Risk of AK and calcium oxalate crystals formation in the kidney.
Correct. So already the kidney is loaded with your high CK levels. You want to add on to that? With marginally or no marginally benefit drug. Shouldn't, no? You should avoid. Albumin, I agree. Some people will use it. And DVT prophylaxis. I wanted to ask one more. Let's just slightly detouring it. Suppose you decide to have give these people antibiotic for whatever reason. Okay. How will you choose the antibiotic and its dosing? Or tell me the basic principles that will differ in this particular patient while using the antibiotic. The same question, the same answer for a different way to be asked in a very theoretical manner. What are the pharmacokinetic changes happen in a burns patient that should be applied while using an antibiotic?
One is volume of distributions and protein binding should be taken.
Perfect. So give me a
Anything
broad commonly used antibiotic which you will feel that they will not be useful and when they will be useful.
Common burn wound sepsis initially will be because of the gram-positive commensals in the skin or respiratory tract or GI tract in the first initial 5 to 7 days. In the later
No,
part,
I understood that. Sorry, I'm not sorry. Let me put the question in. Give me an example of the commonly used antibiotic which will not be as effective in this patient. You said just now, na, the volume of distribution will change. Absolutely. Right? Tell me the antibiotic which has higher volume of distribution, whose tissue distribution is more, and then they won't be much effective. You won't be able to reach that concentration. Quinolones, aminoglycosides, vancomycins, right? Clindamycin, all these things will be very vastly distributed. So you have to be very careful. So whenever you choose an antibiotic, you also have to make sure that your dose is correctly, because it's not going to be a regular dose. It's going to be a different dose for this one.
And you saw that patient is having an infection in the burn wound, and but patient is not having sepsis. So how you want to give the antibiotics?
One is initial wound debridement, surgical debridement is the first thing, sir. And topical antibiotics can be given.
Should be given. Correct.
Yes, because there is a role of IV antibiotics are not there unless patient is having a sepsis, organ dysfunction. Yes.
How will you suspect sepsis in this patient?
There is a criteria according to American Burn Association, sir, which includes a major criteria of presence of either positive blood cultures or clinical response to antibiotics, or tissue cultures growing more than 10^5 per gram tissue, along with the 3 of the minor criteria like presence of tachypnea, tachycardia, thrombocytopenia, fasting blood glucose more than 110, GI intolerance for more than 24 hours, or hyperthermia.
None of them has specificity here.
Yes.
None of them have specificity. So across all the scoring systems and all those things have clearly shown that none of them are specific to tell the patient has got infection. Even your white cell count, CRP, procalcitonin is also out of the roof. It is a pure judgmental call for you to take when you are using an antibiotic. It is an absolute judgmental call. So usually after 24 hours or so, when you start suspecting that, debridement, yes, what you are doing. Why early debridement is necessary in these patients? You can wait, now everything settled, and then you can do it.
Early debridement
And grafting, sorry. Early debridement and grafting.
It reduces the inflammatory response and reduces the risk of infections.
Correct. So earlier this thing. And second thing, another way you can think of that, when the graft starts getting rejected, then you can also think that the infection is setting in. Okay. So early involvement of the surgeon, debriding the wound, making it clean, brushing it with the saline is always important. He was started on the oral liquid diet. Is there anything next on the next slide? A3 selling on the morning. Okay, and this is the same thing. Anything else?
The lab values of in this.
You tell the significant findings, any lab values. Day 5.
Only serum CPK was further elevated, sir, on day 4. On
Okay.
day 5, the patient developed fever spikes and there was gangrenous patches in the left lower limb. So the patient was taken up for the debridement and lower limb was amputated. So below knee amputation was done. Blood cultures and tissue cultures were sent and antibiotics were escalated.
So this was a clearly compartment syndrome was missed.
Before
it?
this, one fasciotomy was done, sir. Before this, day 5. Day 3, fasciotomy was done, sir. Both lower limbs and the.
That means it was too late, na, by that time.
Mm.
The patient has already developed ischemia. Is there any way you know how to look for how to measure the pressures for a compartment syndrome for an apparently normal looking thing? This is one technique which I learned. So what you do is you take this big 18 gauge or 16 gauge cannula, connect it to the transducer, and straight away put it inside the muscle. And you can check the pressures. So that's one of the things. Are you guys missing something important here? You are already reached to day 9, and I don't see anything except one sentence which was written there on the previous slide. You started on oral liquids. Do you think feeding this patient is important?
Yes, sir. Actually, he was having both RT feeds and oral liquids, sir. In between. He was placed on RT feeds before.
Okay, so RT feed. So can you elaborate on that RT feed?
In case
What
of
was the RT feed going on? How did you reach? Nutrition in the buns is a full mark question.
yes. As the burns is a hypercatabolic state, there is a need of high nutrition in the burns patient with a protein of 2 gram per kg per day, sir. And formulas like curare formula has been used in the nutritional supplementation of the burns, which includes 25 into body weight plus 40 into percentage total body surface area involved.
Did you do that?
Yes.
In this patient,
Integrated.
how much was the calorie given? How much was the protein given?
Protein would be around 140 grams per day, sir, as he is around 70 kgs.
So what feed was you were using? The fact that in this making the slides that has been completely, it might have happened. I'm not saying no. Completely, it just indicates that you didn't focus on that. Okay, burns management from intensive care perspective almost becomes after initial resuscitation. There is nothing much we do. It's mainly the surgeons and the debridements and prevention. So only two major things are important here. One, prevention of the infection or surveillance of the infection, and second is the calorie.
Yeah.
These are the only our prerogative. Rest of nothing, we don't. We should know it, but that's not our domain. And remember, these two
How will you
things
assess
can.
that percentage of how much?
Sir?
Yeah. How will you assess that percentage having how much degree of catabolic state, severe hypercatabolic state or moderate hypercatabolic state? How will you assess
How will you
that?
ask the same question in a different way? How do you ideally measure the requirement? Caloric requirement, ideally. Have you
Gold
heard of
standard.
indirect calorimetry?
Indirect calorie. Yes.
Have you ever done? You should get it. It's a very stupid thing. They put a mask or in an intubated patient, they put something. They try to calculate amount of carbon dioxide excreted, and there is a software, and it will completely calculate everything. Okay. I did it for myself. So it's pretty up computerized now.
Yes.
So,
So any other method that is the gold standard, as you told that indirect calorimetry is the gold standard to measure. But for that you need equipment and you need a software and you need carbon dioxide, you need oxygen consumption. So for some difficulties you are not able to do many centers. But if you don't have that, any other things that your calorie assessment requirement, how will you assess and how you decide your protein calorie formula that is fixed for all the patients of burns for around all of the day, all duration. For example, patient stayed in ICU for 15 days. So all these days you want to give that much of calorie?
No, sir.
I mean,
Following the debridement and reduction of the surge response, the calorie requirement is reduced, sir, in the burns patient. So,
so on which day you want to reduce, any particular day, or you want to reduce, or how you want to judge for that? Or if suppose patient is not having fever and you saw that patient is not having hyperinflammatory response, your WBC counts are normal, and but patient is having all means 70% of born wound exposed, and but hyperinflammatory response is not there. So how you want to judge and give your nutrition and calories and proteins on a particular days, individual days? So is there any way to judge your catabolic state on every day? What is most important factor we look at? What is the most important factor we look at when we are assessing a catabolic state?
muscle mass.
Lean body mass.
Yeah, muscle mass is measured by nitrogen.
Blood urea
Blood urea.
nitrogen.
Yeah. So how much nitrogen we are giving to the patient, and how much nitrogen is being lost in the urine? If these two things is easily measurable. So if two things you are measuring and how much nitrogen is lost in the urine, that comes in a negative balance, which gives us a daily catabolic status. So you decide your how much protein and calorie you want to give that point of time.
it's a very ideal way, very tedious way. Sometimes we don't tend to do it, what you're saying, but at least you should be near to what Prusti is saying. And from day 3 to day 9 in this chart, you should also put in how much calorie he has required and how much calorie he has done. Okay. You can go to the next slide.
On day 5, the patient developed fever spikes, so sinus tachycardia was there with maintenance of urine output 70 ml per hour, and which was clear. There was discoloration of left lower limb with gangrenous patch was noted. So left below knee amputation with debridement of other areas like upper limbs, trunk, thighs, leg and face and foot, along with the dressings was done, sir. So patient is having fever spikes, so blood and tissue cultures was sent and started on antibiotics, meropenem and clindamycin. On day 6, patient continued to have fever spikes. So MAP was maintaining and the heart rate was 120 per minute, urine output 70 ml per hour, and GMP flagged on blood cultures. Day 7, patient became drowsy, requiring 2 liters per minute of oxygen, with new onset hypotension requiring noradrenaline support and urine output of 60 ml per hour. ABG showed mild metabolic acidosis with the lactates of 3.5. Echo had showed a good LV function and no RA-RV dilatation. Blood and tissue culture confirmed HDR Klebsiella, started on ceftazidime, avibactam, and aztreonams. Patient had worsening shock and combined respiratory and metabolic acidosis with a drop in GCS. So patient was intubated and started on CRRT. And day 9, patient on dual vasopressors, worsening shock, and patient had cardiac arrest associated according to ACLS protocol, but patient could not be revived. So.
Sad.
Okay, in this scenario, for example, patient, you found that patient had Klebsiella, tissue culture you have sent and blood cultures you have sent, and still you have started in timely basis you have started the antibiotic, but still patient was running fever and going to the worsening shock state. So you say that that was a worsening sepsis. Do you think anything else we should think at this situation, even though debridement was done, amputation was done, or something you would miss, and we should have a high suspicion, and we could have missed something, we could have sent, and we could have find out.
Procalcitonin, sepsis part, sir.
Yeah, sepsis part. Means any other infection, we should have a strong suspicion in this case. When we say that patient had a wound infection, patient had a ischemia, gangrene, and patient had we needed debridement, lot of debridement and amputation, and the patient had a wound infection, but the culture could grow only Klebsiella. There might be some mixed infection. Should we raise and in our mind fungal infection? Should we raise suspicion? Is this patient a risk category for a fungal infection? Yes or no?
Yes.
Large exposed area, and patient had tissue necrosis. You said some degrees of 3rd degree burn, and patient had gangrene, and tissue necrosis was there. Tissue biopsy, if you could send. So tissue culture did not show, only Klebsiella it has shown. So suppose if you send a tissue biopsy, what means even you can look for a invasive fungal infection. The most in the wound infection is
Candida.
no.
In the burns.
Mucor.
Mucor,
Yeah.
gangrenous. Black.
Yeah, Candida also can. Yeah, Candida also possible, but mucor is little. Yeah. So and that will be more confirmed. Candida can grow in the culture itself, but mucor may not grow in the culture, tissue culture. So it again you need to do a biopsy, tissue biopsy. If you do, you can identify your fungal, means mucor if it is there. Could means we should have a suspicion. I am saying it's not that in this case you should have a suspicion. Okay. This patient was having pain and persistent pain. You have given fentanyl maximum dosage. Patient is not responding to the pain. So should you consider for any other drug to control pain, or if you want to any other drug, means why you want to give?
So in short, what are the pain management strategies from mild pain to severe pain? What are the strategies in burns patient?
Multimodal analgesia is preferred, sir, to prevent the overdose of the opioids, NSAIDs, narcotics, and if still resistant to that, tricyclic antidepressants, amitriptyline, gabapentin can be given in such patients.
Beyond
Yes.
that?
Sir?
Beyond that?
Regional anesthesia in case of
during dressing, especially.
Ketamine is preferred for burns dressing analgesia.
Yeah, but it's very, very, very painful. So they may have to do it in the theater under inhalation. So gas inhalation is very, very common. Every time they do a dressing, burns dressing changing is a big thing. They do it in
patient will have a nociceptors because they will have a severe
Especially
pain
when they're
when the
healing.
work
Yeah, when they're healing, new nerve endings are coming, it's extremely painful. Extremely painful.
So
Very sensitive.
you need alternative model. It's multimodal is more important. So it's a gabapentin is a very good drug, and tricyclic antidepressants are also very good drugs. So you can consider along with the baseline these drugs, and along with that we need to give ketamine, fentanyl, all multimodal we need to give for control of the pain. And do you consider in these patients for giving parenteral nutrition if you want to give parenteral nutrition? Because you told that almost so much of calorie, 70 kg person and 70% burn, and your caloric requirement is very high as per Curie formula. So if enterally, if you are not able to give that much of calorie, do you want to give parenteral nutrition in these patients as a supplemental parenteral nutrition? If you want to give, is there any specific indication for that, or no need? I want to maintain with whatever maximum I will try with enteral nutrition only. My question is, should we consider increase for to reach to the goal of calorie? Should we combine or an enteral plus parenteral, or only enteral, whatever maximum should we try?
Only enteral is preferred, sir, compared to addition of parenteral nutrition.
But
If
at the
the
same
patient is
time, patient hypercatabolic state, and you want to start this that much of calorie on the day one itself?
No, sir, graded. We should start as soon as possible within 24 hours. In the graded manner, we should increase, sir.
So that's where the detailed discussion of the nutritional and how to deliver the nutritional comes in. What are the various ways you can discover it? What kind of proteins you are giving it? What are the standard manufactured formulas which you get? So 1 meal, is it 1 meal per calorie, or 1.5 calorie per meal, or 2 cal per meal? That's kind of formula because of the fluid tolerance. Okay. That along with, if you're not able to reach the goal, then sometimes it's not recommended as of now, but people have used partial parenteral nutrition also. However, the risk versus benefits are extremely need to be carefully selected. You are risking this burns patient to the fungal infection, as Prusti said, especially with the addition of the TPN and all those things. So yes, you're right. NG tube and oral feeding is what you should be targeting and aiming from, trying to reach at least 80% of the requirement by the end of first week. That is what the routine recommendation is.
Any role of anabolic patient into the recovery phase? Any role of anabolic steroids here?
Is there any role of any propranolol?
Some patients may develop hypermetabolic state following the burns till 36 months following the burns. So in that cases, we can give propranolol, oxandrolone, testosterone analogs, anabolic testosterone analogs, or metformin to prevent the insulin resistance.
Yeah. Okay. And this patient, you are a plastic surgeon, you are a cosmetic plastic surgeon, is asking you because patient needs an debridement. Patient has a extensive necrosis of the wound, and he is asking you that should you go for a maggots debridement therapy? Maggots
debridement.
Yes. So should you go for it? Should you give permission, or should you agree with him or not?
I don't know.
No, patient is with you. You are the taking care of the patient, and so he is asking you one way of debridement is one is surgical debridement in OT, another is maggots debridement. So they'll put some maggots over the wound, and so that maggots will eat away the necrotic material. So have you any time you heard that is this way available in the world that we can go for it?
I have heard, sir, but haven't seen it.
Yeah, it is there. The people do that.
Yeah.
This part of the world, 1 or 2 centers they have done, but it's not very much encouraged. But
We need to take consent from the family too.
And it's yucky. I've just given it to the panelist.
Yes, sir.
There is
I think you shared a file, sir. Yeah.
Yeah. So just share this file. Just go through this file. It's a quite nice 1-page cheat sheet of initial approach and assessment of the severe burns. Australia and New Zealand burns, there is a website. It is very, very informative. And because here is a pyramid system where people have to transfer the patient to burns specific center. So they have also given a criteria where whom you should be sending it. But it is a very good for initial assessment and management and maintaining this. I just shared it with you, and you can also check on to the website also. If you want to make your center as a burn specialization center, it is a very good thing. It's quite depressing also because sometimes the outcomes are not very good. But as you have seen in this patient, with all the hard work you have done, you have brought him out from the electrical burns and everything, and then he succumbed to the secondary infection and all these things. So it's quite, they are very vulnerable population. So even though we have done a best job, we have to keep maintaining that. So it was
I think we discussed it very elaborately, sir. I think every aspect has been touched upon. So I think I thank you, Saroj Prusti sir and Anand V Joshi sir, for giving able clinical insights and practical knowledge, especially very important thing while practically treating these type of patients. And thank you, Dr. Sindhuja and Dr. Ravi, for bringing out this case, which led to elaborate discussion, very much useful. And digital team and branding team to providing the platform to have these webinars very regularly, and our viewers who are tuned into it very regularly and listening to that. So thank you, sir. Any final comments, sir? Anand sir and Saroj sir.
That's it is the initial assessment and fluid resuscitation is very, very important. We need to remember the because any burn patient, the basic pathophysiology we need to remember is burn suck. So irrespective of the patient's clinical status, whether patient is in shock state is there or not, anticipating the shock state when you categorize that patient is having a severe burn, fluid resuscitation, optimal fluid resuscitation is very important with the ROSE concept. ROSE concept means you are everything, optimization, de-resuscitation, everything counts into it. And monitoring them and how to monitor them in a stepwise, how to give the fluids and what parameters we need to monitor in you are in the best centers. So that is also important. We have
Prusti sir, you are muted, I think. Not able to hear us.
Prusti, we cannot hear you.
multiple.
Yeah. Now we can hear.
Now it's okay.
And the third one is nutrition. So that nutrition is you are in a burn patient hypercatabolic state when you want to start, and means because by the day of 4 or 5 Usually that initially patient in the first 48 hours to 72 hours, usually patient will be in a hypometabolic state. Then again patient goes to hypercatabolic state and hypermetabolic state. That situation you need to increase your calories. So basically, and how to give by monitoring your hypercatabolic state, either by nitrogen loss, or if you have indirect calorimetry, that is best way to monitor the calorie requirement. So and fourth part is infection control, infection prevention and infection control. That is the most important part while the management of burns. All other supportive care, there are some controversies, but still we need to update ourselves once the time passes. That's what I wanted to.
Answer.
So,
Yeah, I think Prusti has already covered everything. Only thing is, don't go with the seagull phenomena. That on the first day, 2 days, everything is done. We do everything, and then we leave the patient, and then we are clueless what to do. So we have to maintain that momentum, because patient can die at any point of time. And to avoid the disappointment after doing such a fantastic job on the first 1 day, 2 day, doing exactly everything what we have done in the textbook, and then we not having clue and then leaving the patient is going to kill the patient. So you need to continue that for a long time. And as Prusti said, infection prevention, which is quite a big challenging in India, it's very important. Keeping him in isolation, strict aseptics, as you do it in a transplant patient or anything. You should maintain it. Anyway,
thank you, sir.
Good presentation.
Yes,
and
sir.
thanks for taking some time.
Thank you, sir. Thank you all. Good night.
Thank you. Thank you.
thank you, Kaladhar.
Thank you, sir.
Thank you, Sindhuja and Ravi. Yeah.
Thank you.
Thank you, sir.
Thank you, sir. Good night, sir.